Hi, this is Elliot Fishman, and welcome to our latest podcast. This is going to be on focal nodular hyperplasia of the liver, how to make the right diagnosis and avoid a misdiagnosis. Now, way back when, 1982, this was probably the first major article I published out of Hopkins, and I spoke about FNH and hepatic adenomas. A total of 5 cases. What a massive series. And here was something we said then: much confusion exists today in the clinical, radiologic, and pathologic differentiation of benign hepatic tumors. We feel that in many cases, the correct diagnosis will be more readily established with the use of CT. Clearly, since not all cases of FNH will have a visible scar, one would not expect 100% accuracy. Yet we feel that if a liver lesion with a central scar is seen, the most favored diagnosis should be FNH. Well, we were pretty correct. We have learned over time that many lesions, from hepatomas to cholangiocarcinomas to hepatic adenomas, can also have central scars. So a central scar in and of itself is not the only thing we think about with focal nodular hyperplasia. It looks different in FNH than other lesions, as I'll show you, because it fills in differently, often has a feeding vessel, and the whole appearance of FNH is different. But that was, 44 years ago. To show you how you move forward, I did a Gemini search today on focal nodular hyperplasia. Look what it says. Typical CT appearance on non-contrast, rich arterial blood supply from an enlarged central feeding vessel, portal phase becoming isodense and remaining isodense, but the central scar typically shows delayed enhancement, and it may appear hyperdense or it may isodense. Okay, and we talk about some of the key characteristic features. It is amazing how Gemini has gotten so good that that's maybe the first place you're going to look now for information. Forget PubMed, forget anything else. Just hit Gemini, and look how it summarizes everything very nicely. And you can even go into less common presentations of FNH, but I did not do that, but we will do that in this talk. And classic FNH lacks fat, calcification, internal necrosis, or hemorrhage. All very, very good points, right? It's well circumscribed, but unencapsulated, kind of more toward a pseudocapsule appearance. A couple of articles, I just want to go through. Some of it will be a little bit repetitive, but I think it's good to hear all the facts. FNH is the second most common benign liver tumor after hemangiomas, 8% of primary hepatic tumors. It's more common in women than men by about 8 to 1. 3rd to 5th decade of life. It's usually singular, but can be multiple. I think hepatic adenomas are more commonly multiple than FNH. It's a benign lesion occurring in a background of normal liver. Okay, so it's not like we say hepatoma is in a cirrhotic liver. So it's typically a benign liver, though you can get FNHs in abnormal livers. In that first article, the point we made was that FNH needs to be differentiated from many things, but particularly hepatic adenomas. They do have different enhancement pattern, as I'll show you, and as we learned over time. Hepatic adenomas commonly will bleed, and FNH does not bleed. Okay, that's helpful. It's a benign lesion of hepatocytic hyperplasia in a background of normal liver. Okay. Again, young women, but it is associated with hepatic vascular disturbances, including abnormalities of hepatic flow and outflow and microvascular disturbances. And that's somewhat kind of easy. Now, one of the things we're going to say is we usually can diagnose hepatic adenomas on CT. We usually can diagnose FNH on CT, but not always. Hepatic adenomas are trickier, FNH is easier. And again, if you know something's FNH, you don't need a biopsy, you don't need surgery, you don't need other imaging as well. Imaging features of FNH correspond well with the histologic features and are similar across modalities. Again, it's well capsulated, but it's really a pseudocapsule, usually 5 centimeters or less, isoattenuating to slightly hypoattenuating on non-contrast scans. And then we see the increased attenuation with IV contrast material and very similar things on MR. Central scar composed of fibrous and myxomatous elements is present in almost all cases of FNH, but that's on pathology, visible in about 60% with CT and about 80% with MR. I think if you look very carefully, you could see it well on CT more than 60% of the time. And again, the large feeding vessel to the central scar is classic. There's no neovascularity, but it's a long vessel. It's thin, right to the central scar, particularly well seen when you look at MIP imaging. Okay? Very, very important. 85% of FNHs are smaller than 5 centimeters and a small percent larger than 10 centimeters. Hepatic adenomas, I think they can be small, they can be multiple, but they typically are larger. Okay? FNH can grow over time and it can regress over time. But most of the time, the lesion does not change a whole lot. So I don't think you really need to worry about that. In this article by LaGroute, making the point you need to have some experience so you don't overtreat the patient, do too many studies, do biopsies, create all sorts of issues. FNH-like lesions are commonly detected from pathanalysis of a liver explant, but are less commonly detected at imaging. So we talk about these FNH-like lesions, where microscopically and radiologically they're identical to FNH, but there is an abnormal liver present. I think we see them far less frequently. They're a bit harder to diagnose. 10% of FNH-like lesions can demonstrate washout at delayed phase imaging, and 3% do not retain contrast. Okay, so just something to consider. Again, we made the point about it. It's a small percent of population, but again, 8-to-1 female, typically the adult population. And what's very important about FNH, it's a benign lesion. If you're staging a patient for a malignancy, whether it's breast cancer, whether it's colon cancer, you don't want to confuse it with metastatic disease. And again, this incidental finding, no malignant potential. Every one of the lesions is managed conservatively, but again, you don't want to confuse it or misdiagnose it with other hepatic lesions, and you don't want to call it metastasis in a patient who may have a suspected cancer. The central scar corresponds to a collection of blood vessels and bile ducts and surrounded by inflammatory cells and encased by a fibrous stroma. And we said that sometimes you can see the scar better on the MR than you can on CT, but this lecture is focusing on CT. FNH is one of those unusual tumors that can be pedunculated. People say 9%. I would say probably about 5% or less. We don't see that many pedunculated lesions. Most of the time when I see FNH, it's well defined within the liver proper. You can see other pedunculated lesions, hepatic adenomas, hemangiomas, but you could think about FNH if you see a pedunculated lesion, and of course the lesion has to behave in the way you want it to. We mentioned about the central scar. Absence of a central scar is the most frequent atypia. Even if all other imaging features are present, the diagnosis of FNH cannot be reached if the central scar is absent in this article by Bergio. Calcification is a rare finding. Calcification makes me think about fibrolamellar hepatoma or hepatoma in general. There was one series that had a couple FNH cases that had calcification, but that's pretty rare. And again, when I see calcification, I'm thinking about fibrolamellar HCC or hepatic adenoma. Hepatic adenomas can have calcification in part because they bleed, and anything that bleeds can eventually calcify. I mentioned this FNH-like lesions. there's a lot written about that lately, so I thought I would share that with you. But it's abnormalities of hepatic outflow or hepatic inflow or microvascular disturbances. So you can see that these lesions can occur, though they're often hard to see on CT, better seen on pathology, but you can imagine a cirrhotic liver, you start seeing something vascular, you got to be thinking it's hepatoma till proven otherwise. So I just want to make the point that we talk about these FNH-like lesions, but it's more on the pathology side than on the radiology side. So let's go back. Let's look at the easy things. What does it look like? Isoattenuating or hyperattenuating on non-contrast scans. If you go at about 35 or 40 seconds, it's hypervascular with a large feeding vessel commonly seen best on the BIP imaging. And then as you track it out to venous or delayed, it becomes isodense. Now with the enhancement, this is very important. It's hypervascular, but it's not as bright as the aorta, only as bright as the IVC. Hepatomas, neuroendocrine tumors, they're going to be bright like the aorta. The feeding vessel, now you can have feeding vessels into hepatoma, but here it's usually a thin feeding vessel. It's not the regular aggressive neovascularity you expect to see when somebody has a malignancy, and it goes right to that central scar, okay? And then we'll watch as the lesion becomes isodense. Most FNHs demonstrate arterial enhancement levels lower than 50% of the aorta, or portal venous attenuation values lower than or equal to those of the IVC. And this is an article from Hopkins, which Pam Johnson helped write. Again, match the IVC. That's really what I want to be looking for. So now let's look at a lot of cases. This is arterial phase. There's a mass in the liver. The liver is not cirrhotic. There's a scar in the lesion. The lesion is homogeneous, it's vascular, and not quite as bright as the IVC. This is a classic look of FNH. Central scar, which can be small. There's also the look here of a second lesion nearby, right? So we can think of that possibility. Here's the vessel going into the lesion on the volume rendered view, and the MIP imaging shows it a little bit better. So now I have a vascular lesion, non-cirrhotic liver, central scar, and a vessel going into the scar. The hepatic artery, the GDA, SMA look good. Then I go to venous phase. The scar is there. The lesion is less well shown. You can see some vessels pushed around the edge of the lesion. You then look at it, all three phases together, arterial to venous to delayed. Yes, I can see it on delayed, but it's nearly isodense. The scar is nearly gone. Just a beautiful classic pattern of focal nodular hyperplasia. Another example, vascular lesion left lobe of the liver. Feeding vessel. The liver, no evidence of cirrhosis. Here's a couple more looks, very vascular. Could this be hemangioma? It doesn't look like hemangioma. It could be metastasis, hepatoma, what else? But you can see as we go to venous and delayed, the lesion washes out quickly. There's the central scar. This is classic for focal nodular hyperplasia. This might be considered a pedunculated lesion, if you really like to call things pedunculated lesions. And here it is again. Just look at that early phase and look how it washes out. Perfect for FNH. Another example. On the image on the left, you can maybe, with an imagination, see a tiny area here of low density, which is the scar. Then you go to arterial phase and you see the lesion enhancing. There's no cirrhosis. The lesion on the left is identical in attenuation to the IVC. It's not as bright as the aorta. So we have a central scar, well-defined vascular lesion, bright like the IVC, in a patient without a cirrhotic liver. The lesion quickly becomes isodense. Yes, you can kind of make it out, but that's the classic washout. And here's a few more images of focal nodular hyperplasia. Another example, almost like the case before, very vascular, central scar. You see the feeding vessel, better seen on the MIP imaging. And there's not much else. Hepatoma, the vessel will be larger. You can get well-defined hepatomas or hepatic adenomas, but they're going to be brighter than this lesion. Also with hepatoma, it's usually not so homogeneous. Just a really good look, and I'm rotating the images. You can see the feeding vessels. And again, the vessels are all small. They're all thin. And now we wash out the lesion, central scar. Lesion is getting near isodense. Compare the arterial and the venous images together. And then start looking as we go toward the delayed phase imaging, where you can see a vessel stretched out, but the lesion is hard to see. You kind of know it's there. The scar is basically gone. There's just some stretching of vessel. Very nice for FNH. Okay? It's not the look of hepatoma, not the look of metastasis, surely not the look of hemangioma. It's not the look of hepatic adenoma. Another case. Well, this one you can see this was the same patient, but look how the lesion becomes basically gone. So when I say it's isodense, it doesn't mean you can't recognize it, but it's hard to see. Might be a better description of isodense. And again, here's just a few more images of that patient. Okay? I want to really make sure you appreciate the changes in how the lesion goes from arterial to venous to delayed, and how by looking at it and studying its enhancement, studying the scar, the central feeding vessel, you can reach the right diagnosis of FNH every single time. Okay, and here I'm just bringing back the images, going from delayed phase to venous to arterial. Another example, lesion right lobe of liver, looks like the IVC density. FNH will vary a little bit in brightness depending on how fast you inject. The faster you inject, it may be a little bit brighter. But there's the lesion, well defined. You don't see the scar very well in this case, but you see some small feeding vessels. There's no cirrhosis. This is a larger mass, and it's solitary. It's stretching the vessels, and then it becomes isodense. Just a really good example of focal nodular hyperplasia. Here's a few more views in 3D of that right lobe of the liver. And again, the lesion, you kind of can imagine something, but it is isodense. Now, again, here's a good example, and I'll stop after this case and we'll take a small break, come back, do a little more cases, and show you some new ways of thinking about FNH. But here's a very bright lesion, right lobe of liver. You can say a bright lesion, hepatoma, metastasis, but you have that feeding vessel going right to it. And then you look at it carefully. The vessel is small in size. It's not that irregular vessel from you would see with malignancy. Again, looking at it very nicely, you can see it go to the center of the lesion. Here it is on the coronal views, okay? And you would say hemangioma doesn't look like hemangioma, doesn't look like hepatic adenoma. Could I 100% rule out a MET just if I look at the brightness, or hepatoma? Well, hepatoma, it's not a cirrhotic liver, but theoretically a MET could look like this until you analyze the lesion better. So when you analyze and you see that feeding vessel, that's FNH, okay? That's not a metastasis. That's not what it is. And then you could see as you go from the early phase to the late venous phase, the lesion is basically gone. Yes, hepatoma, yes, metastasis can become isodense, but not this well and not without some type of liver distortion. Okay, and the later phase, you just don't see anything. And another one, okay, there it is. Looks the same as the prior case. Feeding vessel, no cirrhosis, no other lesions. It goes from bright to near isodense. Really nice for focal nodular hyperplasia. And here's just a few more images. This emphasizes the point you could study the FNH on the axial imaging, but you need to use MIP to look at the vessels to the center. And I think coronal imaging proves to be very helpful, really, to understand the full component of the lesion. And again, you see next to the hepatic vein what looks like some of residual tumor. So it's isodense but not gone. That's a nice way of putting it. We are doing work with cinematic rendering, and cinematic rendering is really good at picking up liver masses. There's the FNH right there. Really stands out nicely on the arterial phase imaging. And then you can see as you go to late phase imaging, you can kind of see it. There's the vein, but there's the lesion. But it is nearly isodense, and that matches very nicely with the routine coronal images. And again, in this case, you see the portal vein and SMV. Everything looks good. There's no other findings that make you think about malignancy. So let's do this. Let's stop here. Let's come back and do some more cases. Again, I want you to be perfect on FNH, and then I want to tell you some of the new ideas of how we can look at FNH. See you in a couple minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.